All right, then we're going to go ahead and get started with talking about hitting the highlights for acidosis, alkalosis, fluids and electrolytes, chronic kidney disease, and SIADH and DI. This is Shanna Parker, by the way. So here I have a normal arterial blood gas that is going to be taken from a radial artery or a femoral artery in an emergency. The patient may also have some sort of arterial line that they can draw that off of. So we'll start by looking at the normal. pH normal is 7.35 to 7.45. Partial pressure of oxygen, or PaO2, is normally 75 to 100 millimeters of mercury. PaCO2, the carbon dioxide, is normally 35 to 45. Bicarbonate is 22 to 26 milliequivalents per liter. Normal oxygen saturation is 95 to 100%. So how does the body maintain a normal pH? What happens when the pH is not normal? How does the body respond? So too low, less than 7.35, that's acidotic. And too high is greater than 7.45, so that's alkalotic. What are some symptoms for acidosis and alkalosis? What are some causes? And I'm going to talk about this later in the slide, and we'll practice this on Thursday as well. What are the 3 steps of ABG interpretation? So we're not going to look at that right now. So with acidosis or alkalosis, there is a net gain or loss of hydrogen ions in the extracellular fluid. Our pH is affected by how much carbon dioxide we exhale or that we retain. Our pH is also affected by our kidneys, which reabsorb bicarb from urine back into the blood and excrete hydrogen ions into the urine. Our brain and kidneys take care of this automatically. So our kidneys are closely interconnected to CNS and afferent impulses. For breathing, that's taken care of automatically by the central brain control. We may have some control if we're conscious, but mentally, if we're trying to think about breathing, we can't keep up. The brain is going to take over to maintain homeostasis. Basically, if our pH is too low, our brain will speed up the respiratory rate to blow off the CO2. Technically, CO2 or carbon dioxide becomes carbonic acid when it mixes with water in the body, but I like to think of it as blowing off acid. If our pH is too high, our blood is alkalotic, then our brain tells our lungs to slow down and hold on to the acid, hold on to the carbon dioxide or CO2. Some of the causes and symptoms are based on if the issue is related primarily to the respiratory or the metabolic systems. Think about what's happening at the cellular level, particularly with acidosis. The cells don't like it. They start to malfunction. Think about the body systems head to toe. If our brain cells are being bathed in acidic blood, are we going to be thinking straight? So this can affect very many areas. The causes also vary. For the respiratory acid-base imbalances, think about what interferes with good respiratory function. So if someone has pneumonia or some lung disease or COPD, so those could impact how well the person is able to the respiratory system is able to help with that balance. Think about what controls the respiratory system, so the brain. So if there's some kind of head injury or accident or something like that, that's going to impact, it may impact their respiratory system. For kidney acid-base imbalances, think about what interferes with good kidney function. What controls or impacts the renal system. So the central nervous system is going to impact that, but also say there's some sort of high blood pressure, or the patient has history of high blood pressure, and or they've had some sort of medication that has been toxic for their kidneys, or otherwise impacted. So if the kidneys are impacted in any way, that's going to affect that acid-base balance. Okay, so and then we are going to be working on ABG interpretations. I'm going to talk about that just a little bit in this audio lecture, but we're going to practice that more on Thursday. So let's look at causes. As I said, it depends on where in the body there's an issue. So usually it's going to be something to do with the brain, something to do with the lungs, something to do with the kidneys. So nursing care and process is going to be related to these symptoms and causes. We're also, so we will be doing our, our assessment. We're going to be assessing the lungs, assessing the full body, assessing neurological. We're going to be following up on ABGs and lab values. We're going to be doing good INOs, making sure that respiratory pulmonary care is in place. So if they have a pneumonia, we're going to try to help them. Whatever the case may be, we're going to try to help them deep breathe and cough. We are going to follow up on making sure that we work with respiratory therapy to get their albuterol treatments and things like that. Give medicines as ordered if they're on antibiotics, if our lungs are not functioning as well because they're have a pneumonia or something like that. So whatever the case may be, we're going to be doing our normal nursing care and related to that, but we're also going to be paying attention to the arterial blood gases and following up on those and reporting those values to the doctor. All right, so, and then as far as patient family education, that's going to be related to the above. So we're going to be explaining why we're doing what we're doing. What does it mean that the patient has respiratory acidosis? What does arterial blood gas mean? When we use all these acronyms, if we say ABG, they don't know what we're talking about until we explain that. They may be asking, why is he acting weird, or why is she acting weird? And it may be because of their pH. So we want to explain what's happening to their family member, and we would want to explain to the patient as well. Collaborative care, of course, we're going to be working with the physician, or the healthcare provider, probably a respiratory therapist, the lab staff, making sure that those timed labs are being completed. So again, I talked about the causes. So any kind of, sometimes it's drugs that are depressing the respiratory system or the center. Say they are have some kind of paralysis disorder, or are newly paralyzed from a back injury or a spinal injury. Say they've broken a rib, so they're not able to take those good deep breaths, so they're retaining more acid. And again, pneumonia may interfere. Pneumonia, asthma, emphysema, pulmonary edema. So these may all lead to respiratory acidosis. So if we had the ABG, it would have a low pH and a high CO2. Symptoms include neurological ones like headache, blurred vision. They may be restless initially, and then that may change to a decreased level of consciousness or lethargy. They might be disoriented. They may be having muscle twitching. So initially, the respiratory rate is rapid as the body is trying to compensate, but then it becomes more depressed as it adapts to the increased CO2. So elevated CO2 concentration causes vasodilation as well. So they may experience a low blood pressure and their skin may be warm and flushed initially. For compensation, the kidneys are going to try to retain bicarb and eliminate more acid through eliminating the hydrogen ion. Then for respiratory alkalosis, so this is the case where the patient is breathing off too much CO2. So they may be anxious. This could be related to aspirin intoxication, could be related to sepsis, could be that they're on a vent and the respiratory rate setting is a little too high. So we keep track of all of those things. Basically, excessive CO2 reduction in the blood, they're blowing it off too much. So that's the pathophysiology. So when you get the ABG on a respiratory alkalosis, the pH is going to be high and the PCO2 is going to be low. Also causes neurological symptoms, dizziness, confusion, can go all the way to paresthesia, convulsions, and coma. Compensation, we would want to decrease the hydrogen or the body. We would want their body to be doing this. The hydrogen excretion will be decreased, so they're going to hang on to the acid to try to compensate for that alkalosis, and bicarb reabsorption by the kidneys as well will be increased. Okay. And similar as far as metabolic acidosis. So again, nursing care and process is going to relate to the symptoms and the causes. So for metabolic acidosis, it can be caused by diabetic ketoacidosis, renal failure, because if the kidneys are not doing their job, they may not be able to excrete acid as they normally do to maintain homeostasis. Starvation is another one. Severe diarrhea, also related to that. So that they're giving out too much base from the other end, so to speak. So the findings on an ABG for metabolic acidosis is it's acidosis, so the pH is going to be low, and also the HCO3 is also going to be low because they're getting rid of too much acid. The symptoms: lethargy, confusion, nausea, vomiting, abdominal pain, possibly coma. So compensation, the lungs, when it's metabolic acidosis, the lungs will try to help by the CO2 excretion will be increased. So the respirations will be deep and rapid. So the kidneys are causing the acidosis, so the lungs are going to try to help out by breathing off the acid. The body tries to increase pH by expelling that CO2, but the body is going to fatigue. So then metabolic alkalosis, this can be caused by severe vomiting. So I think of this as they're puking up the acid, and so they're becoming more alkalotic. Gastric suctioning, and then it says high sodium bicarb intake. So I'm not sure if people do that on the outside, but perhaps they got, as part of some sort of treatment in the hospital, they got like an amp of bicarb. Maybe too much, so now they're alkalotic, or perhaps the kidneys are not able to get rid of that fast enough. So basically the pathophysiology is a loss of a strong acid or a gain of a base. Again, findings on the ABG, the pH is going to be high because it's alkalosis, and the HCO3 is going to also be high because that's a base. Symptoms are going to be weakness, muscle cramps, hyperactive reflex, lethargy, confusion, convulsions, and possibly atrial tachycardia. For compensation, now the lungs will try to help by, they'll help the alkalosis by trying to hold on to the acid. So the respiration rate will slow down, and maybe the respirations may become more shallow as well. So when we're talking to the patient and family, kind of just describing everything that we're doing, telling trying to explain this in layman's terms to the family and the patient if the patient is cognizant enough. They may be concerned about why the patient is confused or why this is happening. So a lot of times it's helpful for them to know it's not their brain, it's their, it's their the pH of their blood that's causing them to act this way. Let them know we're watching them very closely. So of course we let them know what we're doing for them treatment-wise. Collaborative care, we would probably again still be involved with speaking to respiratory, of course the lab staff and the healthcare provider as we report all of our findings and try to try to think ahead. So I said we were going to talk about the 3 steps to ABG interpretation. So we will go over that more on Thursday, but basically the goals of ABG analysis is first we have to decide, is it acidosis or alkalosis? So if the pH is less than 7.35, we know that that's acidosis. If it's greater than 7.45, then that's alkalosis. Then we have to decide, is this metabolic or respiratory? So usually we're presented with that primary issue. And then we're going to look at if it's fully compensated, partially compensated, or uncompensated. Okay, so let's look at this grid to see if we can figure out some compensation scenarios. So again, we'll go over this more on Thursday. But if so basically, the blood gas is considered, the patient is considered fully compensated if the pH is normal. So if the pH is normal, the patient is considered compensated because that's what we're aiming for. No matter what these other numbers look like, if the blood pH is in the Goldilocks zone here, it helps the functioning of the cells. So that is fully compensated. Partially compensated is if all 3 values are abnormal, which doesn't sound like that sounds right at first, but basically one of these systems is trying to either go up or go down based on what type of acidosis or what type of acidosis or alkalosis, respiratory or metabolic. And then it's uncompensated if the pH is abnormal and the either the CO2 or the bicarb, one is normal and the other is abnormal. So let's go ahead and look at these. So this first one says that it's uncompensated. So let's look at the CO2 and the bicarb. First of all, the pH is uncompensated, 1, because the person is still in acidosis at 7.13. So if something is compensated, the pH will be normal. So right off the bat, we know it's either uncompensated or partially compensated by looking at that abnormal pH. Then we look at the PCO2, which is 47. So that is, that's a little bit more than normal. So it's trying, the CO2, they're trying to blow off the CO2. But it's not working. So it's abnormal. So one is abnormal, and the bicarb is normal. So one is normal, one is abnormal. The pH is still acidotic. So this is considered uncompensated respiratory acidosis because the CO2 is the one that's high. So that makes it a respiratory acidosis. So here, let's look at this one that's respiratory alkalosis partially compensated. So if it's partially, then all three values are abnormal. So the pH 7.48 abnormal, PCO2 31 abnormal, and the bicarb level of 21 also abnormal. So the CO2, this is a respiratory alkalosis. So the CO2 is too low. It's blowing off the lungs are blowing off too much acid. The kidney is trying to compensate. So the kidney, the acid is in the acidosis or the acid range. It's less than 22. So the kidneys are trying to make up for the respiratory alkalosis. So it's partial compensation because the pH is not normal. So that's what we look at for full compensation, is a normal pH. All right. And then our bottom one, with pH is normal. The CO2, 32. All we're really looking at is the pH. So if the pH is normal, that's the only value you need to know that it's fully compensated. And we'll have more practice with this on Thursday. All right, so let's look at fluids and electrolytes. So euvolemia is our just right state of being. Problems are going to happen when there's too little fluid, or hypovolemia, or too much fluid in the body, or hypervolemia. So what are some causes of hypovolemia? So that could be blood loss, excessive sweating, not drinking enough fluid, meds or condition that make you urinate a lot. We treat this with either drinking more fluid or drinking like electrolyte replacement if we're out in the world, or we might have to get IV replacement depending on the situation, or other treatment if it's related to some kind of trauma where we've had blood loss. So what are some causes of hypervolemia then? So there may be excessive intake, or not enough urination. There may be some kidney issue. There may be meds or conditions that make you retain urine. Treatment can include fluid restriction, or it can include diuretics, dialysis, so that sort of thing. And then we look at also, what do we want to look at our electrolytes. So these are our main electrolytes in the body fluid. Sodium, chloride, magnesium, calcium, and potassium. These help balance fluids in the body, helps to maintain the blood's proper pH, so they're involved with the pH. And they also help to carry electrical signals from the nerves to the muscles. So we need our proper amount of electrolytes. So what happens if an electrolyte is too high? Can it be removed? Can it be treated medically? If there's too much of something, usually it's a potassium is often an issue. It may be an electrolyte that may be dialyzed. If a person doesn't already have, is not already receiving dialysis, so they don't have that AV fistula. Some places do have healthcare providers who place a special temporary hemodialysis catheter. It's like a central line, but it's for doing dialysis through. And that could be one method of treatment. I didn't look this up before, but there are some type of like binders that people can take by mouth to bind to, say, potassium in the gut. So they take this oral, it's either a solution or I forget if it's some sort of pill or something like that, and it helps to bind to potassium. I'm not sure if there's other binding type oral medications, so that may be one thing to help excrete a electrolyte that's too high. Then as far as what do we want to know if we're going to be giving potassium, or if something's too low. So there's precautions particularly for giving IV magnesium, IV potassium, and sodium, replacing sodium. So basically the magnesium and the potassium, it can have an impact on the electrical conductivity of the heart. So too low, it's going to make the heart be very irritable. You might start seeing more PVCs and that sort of thing. And but we don't want to replace it too fast, because that can also be an issue. So a person that's getting magnesium and potassium replacement, for one, it's not done too fast. Usually it's like 10 over an hour for the potassium, 10 milliequivalents per hour for the potassium. Magnesium, I think, goes over like an hour per gram or something like that. So also these people need to be on electrocardiogram or EKG continuous monitor, because it can have that effect on the heart. We would also not want to replace magnesium too fast, because it can affect the blood pressure. It can drop it, can have a rapid drop with that. So we want to be monitoring. So we would be monitoring vital signs per the hospital policy, and then monitoring the rhythm as well. So, and then as far as sodium, you don't want to replace that too quickly. So if it's a low sodium, so what a typical scenario is, we have patients, especially I hate to be gender specific, but typically in my experience, it's been older women who are trying to stay hydrated, and then they are too hydrated, and then their sodium is low. So there's a teaching opportunity there, as far as, you don't need to drink a gallon a day of water, or whatever the case may be. But then when we're replacing sodium, that has to be done very carefully. You don't want to replace it too fast, because it can actually cause too much fluid shifting throughout the body, but they're especially concerned about too much fluid shifting in the brain. So we don't want there to be like swelling in the brain from too rapid of sodium replacement. All right, so and then as far as fluid issues, looking at too much or too little, so same thing, we're looking at why is this person, if they're overloaded, is it because their kidney is not working, and they're not, for some reason, they're not able to urinate? Do they have congestive heart failure? There's some sort of issue with retention. And then if they have too little fluid, if they're hypovolemic, we want to make sure to replace that fluid. Find out why it's low. Sometimes it's from dehydration, or maybe they've had blood loss, so they may need blood replacement as well. For giving Lasix, so we do want to know, and I always want to check this in a hospital setting, because Lasix tends to be associated with pulling potassium from the body and pulling magnesium from the body. If potassium is low, I'd like to get a magnesium check as well. So what I like to know before I give Lasix is I like to check that potassium, because oftentimes it's the Lasix be given day after day after day. They get their lights drawn in the morning, and I'll check that before I give Lasix, because a lot of times it's like, oh look, it's the potassium is 3.2. Do you want that replaced before? I'll talk to the healthcare provider. Do you want me to replace that before I give the Lasix, which is going to drop that even further? So I do like to check those just to make sure. If a person I talked about precautions as far as the electricity in the heart, and too fast would make the blood pressure possibly drop with magnesium, and have some issues with potassium affecting conductivity and that sort of thing. The other precaution for replacement of potassium especially is having a really good IV, or they may need a midline IV, something a little bit more stable and in a bigger vein, because if it infiltrates, it's very painful. So we want to make sure that it's in a good line. All right. Okay, so then nursing care related to the above. So of course we're going to be monitoring our patient, checking the order, be sure to contact a physician if the patient is getting Lasix and they haven't had any kind of potassium check or lab done. Do they want that done first? And if it's low, do they want potassium replacement first before they get Lasix? And of course, we're going to include the patient and their family as they give permission for that, explaining what we're doing. We're going to be monitoring the labs. We're going to be replacing these electrolytes, and why. Sometimes I'll get questions about why is the sodium replacement so low, so I have to explain how that too rapidly can cause basically swelling in the brain. So we just want to keep our patient and family in the loop with all of that. Collaborative care, most of this is going to be with the healthcare provider and the lab. Okay. All right, let's go ahead and talk about chronic kidney disease. Chronic kidney disease is related to chronic health issues like hypertension, diabetes, nephrotoxic meds, or drug use over time. Chemo can be really hard on the kidneys as well. Chronic kidney disease can result from an initial acute kidney injury or from repeated cellular damage from chronic issues. All right, so we'll just kind of look at this. So chronic kidney disease causes, they're related to these things that impact, basically it's impacting perfusion of the kidneys. So diabetes, if they are poorly controlled diabetes, it can impact, too much sugar in the blood can impact function and kind of make things not perfuse as well, cause cell breakdown. Same with high blood pressure. Heart disease, if they have a history of heart disease, usually if there's high cholesterol or plaque lining the vessels to the heart, that's often the case throughout the body. So that may be in the vessels that feed the kidney as well. Obesity is typically associated with the heart disease. It can be. And then family history, sometimes there may be a genetic component. People over 60 are at greater risk, and because basically everything's starting to slow down and not work like it used to. And then also if the patient has a history of smoking, because that does impact the vascular system. So kidney failure, we want to, I talked about acute kidney failure. So basically, initially there's reduced output. The filtering isn't working as well. The legs, the ankles, the feet get swollen. Person feels very fatigued, associated with high blood pressure. And again, as those metabolites are not being filtered out, the person gets more and more confused. It can affect their neurological system. And then a person with chronic kidney failure will have abnormal blood and urine tests. So they may have chronic elevated BU and creatinine. They may have chronic elevated potassium. They have to go in usually for dialysis, maybe a few times a week. And some people are non-compliant with that, so then they wind up having worse and worse symptoms. They would typically have high blood pressure as part of their chronic kidney failure. So when we're thinking about nursing care and patient education, especially with the chronic folks, with the acute, we want to emphasize, if they want to follow up with their physician, hopefully they'll be able to heal from it and not have it turn into chronic kidney failure. But we would want to make sure that they follow up with their provider. For the chronic kidney failure folks, sometimes the symptoms are they're starting to feel unwell at home as these toxins are circulating throughout their body that can show up on they have itchy skin as well. They start having some of these other symptoms of uremic frost, which is this sort of look on the skin that looks like they got left outside in the cold or something. It looks very discolored and abnormal. So with these folks, there's a lot of, I would say, motivational interviewing, therapeutic communication to help them follow up with continuing to go to dialysis and following the plan of care as far as what they can eat and decrease their potassium intake, decrease their salt intake, and be mindful of how much fluid they're drinking as well. All right, so let's look at what is antidiuretic hormone. This is secreted by the pituitary gland. I've got a little picture here on the right that you can see the pituitary gland. They're kind of in the middle. So if you're looking at the bridge of the nose and go just behind the nasal bone area in the back here, back of the throat, it's just this little thing that's there. So thinking about where that is, you can see how that's in a vulnerable spot. So our antidiuretic hormone, think of it as anti-P. Sorry to be vulgar, but that's just how I remember things. So it stimulates water retention in the tubules of the kidneys, which means less water excreted via the urine. It does regulate and balance water in the blood, and it stimulates vasoconstriction to increase blood pressure. So ADH is also called vasopressin. So we have a synthetic form of this that we can give to people as a medication. So syndrome of inappropriate diuretic hormone. So that means it's inappropriate. It's too much hormone, so they're retaining fluid. And there's many causes and medications. You can see here on the slide, it can be tumors, it can be pulmonary disorders, CNS disorders, many drugs, SSRIs, tricyclics, vincristine, so some chemo things can cause that. Other miscellaneous causes can be, I think that says HIV infections, then different types of things there on the list. Can't see that too good. Then for diabetes insipidus, so this is different. So they're both related to the pineal gland, but with the diabetes insipidus, the person urinates too much. So central DI has many possible causes. The principal cause is the approximate frequencies happen approximately related to these. So idiopathic is 30%, benign tumors of the brain or the pituitary, 25%, cranial surgery, 20%, head trauma, 16%. So I don't see this very often where you're having to empty a full Foley bag like every hour. I mean, it can be quite astonishing. But when I worked in trauma, and I took care of head injured patients on a regular basis, I did encounter this more often. So we can kind of compare, I should have wrote lab values here, but here's our lab values, SIADH versus DI. So you can just take a look at this here. So the sodium is less than 135 and antidiuretic because we're retaining fluid, so this is being diluted. So you can think of it that way. So this is relative to dilution inside the body. The person is not typically dehydrated. They are going to have those neurological symptoms of confusion, and basically it's essentially dilutional low sodium. So low sodium is going to cause some neurological symptoms as well. And then for DI, so they're urinating too much, so it's going to be high urine output. Their sodium, since they're urinating out their urine and tending to retain sodium more, so that's going to be above 135. It actually might be normal. I think normal is 135 to 145 or something like that. Urine sodium is decreased. Osmolality is below, so it's very dilute. Plasma osmolality, I think that's a little bit above normal. Hypotension, because they're getting rid of so much fluid, they're actually dehydrated and they are at risk for seizures and coma. So to help us kind of keep track here, if you think of the phrase soaked inside for SIADH, so the person is retaining fluid and their sodium is dilute. So soaked inside for SIADH. And then for DI, they're dry inside because they're urinating, they're peeing out all their urine and they're dry inside. Okay, that might help a little bit. Nursing management for SIADH, so this is the person who's retaining fluid. We're going to be watching their mental status, looking for overload really. So pulmonary assessment is really important to see how their lungs are doing with all this extra fluid. Cardiac assessment, they may be hypertensive, and it may be causing a strain on their heart enough to be causing dysrhythmias. We want to watch for seizure activity. Very strict monitoring of I&O, strict daily weight, same time, same scale, same clothes or whatever they're wearing, good oral hygiene, and of course our normal nursing comfort. And of course we'd be explaining to them everything that's going on to them and their families if they have permitted that. So let's go ahead and look at care for the patient with diabetes insipidus. Good history assessment. Of course, vital signs. So this is the person who's putting out a lot of urine. Intake and output, strict daily weight. We're assessing their normal urination habits, a neurological assessment, and then we're going to be following these all of these lab values. So we continue to assess, monitor I&O. We're going to be encouraging fluid intake. Medication management is we kind of give a version of the hormone that's not working anymore, so either vasopressin or desmopressin. And then thinking about what type of fluids, hypotonic IV fluids will help to pull the fluid into the cells and out of the extracellular space. So that would be, if that's in use, that may be ordered by the healthcare provider. And thank you very much.